Hey guys, today we're going to be speaking about a case presentation for the gastrointestinal system. So, just introduction about this patient. He was admitted into the Dallas Methodist Hospital. He was 71 years old. He's originally from Cameroon, and the date he was admitted was 7th March, and he discharged on 14 March. His chief complaint is going to be a 71-year-old male with 2 episodes of hematemesis, bright, bright red blood, 4 hours prior. His accessory presental illness, he has 2 days of postprandial vomiting, diarrhea, generalized weakness. He then develops acute hematemesis. He reports dark stools, melena. He has no B symptoms, no history of no history of TB contact. He has no chest pain, palpitations, shortness of breath, or swelling. No skin lesion, no skeletal defects, and he has normal urinary habits and output and frequency. His past medical history is coronary artery disease, angioplasty with stent 4 months ago. Yeah, he has diffuse atherosclerosis. He has no history of diabetes, hypertension, asthma, and he was previously hospitalized once for a car accident which occurred 20 years ago, and he also went underneath a ACL surgery 5 years ago prior. We can see the review of systems and the medications. We can see that he had no fever, no headaches, dyspnea initially, and he has melena. And we can see medication rosuvastatin, clopidogrel, aspirin. He's on dual antibiotic therapy as he did have a angioplasty stenting which occurred 4 months ago. Social history that he lives in Cameroon. He is married. He has 3 children. He's a retired truck driver and a bus driver. He's a non-smoker. He does not drink alcohol. He does not have any illicit drug history. He is insured. He has no history of similar illnesses in the family, and he has no history of unexplained premature death in the family. So, what other history information do you want to know? Just a brief summary that he is a 71-year-old male with 2 episodes of hematemesis, and which occurred 4 hours ago. History presented illness includes 2 days of postprandial vomiting, diarrhea, generalized weakness. He develops acute hematemesis. He has dark stools as melena. His viewer system shows nothing significant apart from melena. He did go under angioplasty 4 months ago. His meds are dual antibiotic therapy, and he is in Cameroon. So you guys can write in the comment section below, or you can unmute your mic and possibly ask maybe some other history information that you would want to know about this patient. Okay, so now let's make a differential diagnosis based upon the history. So let's make a differential diagnosis based upon this history. So we can see this patient is 71-year-old male, uh, a 2 episodes of hematemesis, 4 hours prior. He has 2 days of postprandial vomiting and melena. He had a bypass surgery 4 months ago. He's on dual antibiotic therapy in Cameroon. So maybe over here we can make a differential diagnosis. You guys can write in the comment section or in the open your mics and just to discuss what are some differential diagnoses that we have based upon the history so far. So yes, here are some differences that that we came across: popliteal disease, gastritis, gastropathy, esophagitis, GERD, dual antibiotic-induced bleeding, and he has infectious etiology due to Cameroon. An interesting one is a fistula with esophagus due to coronary artery bypass stenting, and some rare ones are angiodysplasia Delafoy lesions. Let's now coming into the examination, vitals physics exam. He has Glasgow scale of 50 on 50. He's not dyspneic, he's not febrile, he's not pale, he's not jaundiced, no palpable nephropathy, and he has no extremity edema. His vitals are elevated. He has a fever with 100.22 Fahrenheit. He is tachycardic 106. Blood pressure is borderline, saturation 94. General examination shows weak, dehydrated, abdomen soft, non-distended, no stigmata or chronic liver disease. Initial labs is going to be 14.6, white blood cells is 13.8, platelets is 17,178, AST is 131. Urinalysis is going to be normal findings. Hemoglobin A1C 5.9%, bleeding is 5 minutes, prothrombin is 30 minutes, partial thrombus is 31 minutes, ECG normal sign is written TSH 1.2 micro units per liter, and for magnesium is 2.1 and phosphorus is 3.1. So we can see that white blood cells are elevated, so we're thinking about some infection. EST is quite elevated. We can also see over here that hemoglobin, although it's normal, it can be misleading. And imaging endoscopy is going to be POCUS, was initially done, and it was shown normal. Chest X-ray was also done. It showed minor pleural effusions, and an endoscopy was then performed, and showed that there some ulcerative hemorrhagic esophagitis, and we can see this here. There was a clinical turning point. Patient later developed fever, headaches, chills. You can see the hemoglobin does decrease, platelet does decrease. White blood cell normalizes CRP over 96, and we can say thick and thin smears shows positive from malaria. So now, just to give you guys a summary of our so far, there are 71-year-old male, 2 episodes of hematemesis, 4 hours prior. He has two days of postprandial vomiting, bleeding, CAD, angioplasty with stent. He has aspirin clopidogrel, lives in Cameroon. Temperature is 107, 122 Fahrenheit. Endoscopy is ulcerative hemorrhagic esophagitis. Patient shows fever, chills, headaches, thin, thick smears. Is positive malaria. I just want to just get the audience input and their insight, like what could be some final diagnosis, what comes to mind. You can, of course, put in the chat or open the mic and say this. So here was the final diagnosis: medication-induced esophagitis causing upper GI bleed. Likely worsened by the aspirin, clopidogrel. He also had vomiting, so that could have worsened it. An acute melena infection, mass during hospitalization. For management, we give two large bore IV lines, IV fluids, crystalloids initially, type and cross match. We give IV pantoprazole 120 milligrams per day. The dual preparatory therapy was held temporarily, and there was a consult with cardiology. Then we did IV artemether lumefantrine. So we're gonna give 20 milligrams of artemether and lumefantrine. And here's just a brief a workup of GI bleeding. Upper GI can be peptic ulcer disease, esophagitis, Mallory-Weiss, which is likely seen in alcoholics. Our patient was non-alcoholic. Varices is cirrhosis, and we can see risk factors as NSAIDs and dual antiplatelet therapy, vomiting, and liver disease. And that's the case. Thank you. And if you have any questions, please feel free to ask. Thank you guys very much for your time, and I hope to see you guys next time.